When we were putting our program together, we talked to all of our partners each year, and we try to get feedback from each of you about topics of interest, evolving topics, as well as areas that are emphasis within our institutions. And this next session is probably one that there is no meeting going on anywhere in the country about health care that this topic is not finding itself on the agenda. And that's combating the opioid crisis. Again, one of those things where Alabama being ranked #1 is not a good thing, but Alabama has the highest prescribing habits for opioids of any state in the country. It is something clearly we can't be proud about. It is clearly something we need to get our hands around. But before you can make changes and improvements, you've got to understand it. And that's part of the reason we're putting it on the agenda today, is we wanted to bring in expertise to share with you their view from both a national platform in terms of physician-specific perspective, what is going on in the opioid area. We have Blaney Koen, who is here with us from Chicago. He is here from the American Medical Association. We appreciate Mark Jackson and the Medical Association for making him available to us today as our speaker. He is the Senior Legislative Attorney with the American Medical Association's Advocacy Resource Group, and he's going to be sharing information about the scope of the problem, some of the various policy issues that are being addressed out there, and solutions and best practices from other parts of the state, or other parts of the country, excuse me. Currently, he focuses on state legislation and policy. We had the pleasure of spending a few minutes with him at breakfast this morning, and I think he's going to have a number of perspectives that will be helpful to us. And I guess as I step down, I want to say to you, as you think about it as a quality person in your organization, think about the implications for these individuals. What are we doing to contribute to the problem? What are we doing to help solve and intervene in the problem? And what is it even outside of our institutions that we may be called upon to be a part of to help try to face and solve this issue? So wear all of those hats as you're listening to Mr. Koen today. I think you walk away with some expertise and knowledge in that regard. So it's my pleasure, Mr. Koen.
I'll be right here. And I apologize for that saying August. I promise you this is up to date for October. Thank you again for everybody being here. And thank you to Rosemary and to Margaret and Mark and Dr. Chappell and Keith. One of the things that I hope to do today, is talk about, what we can actually do about this epidemic. And, in our work at the AMA and the Advocacy Resource Center, one of the things that we like to emphasize are actual solutions, things that work, and identify, what doesn't work. My background is I have a little bit of a varied background, but at the end of the day, we want to spend our time on efforts that actually have a meaningful impact. And so what I hope to talk about today, some of it will be at a 30,000-foot level, some of it will be a little bit more granular, but throughout the talk, I want to try to present solutions and have that be the takeaway. I try to pack as many takeaways as possible, into this talk. And if I happen to look down like this, I promise I'm just trying to keep on track for time. So I promise I'm not being rude. I know I'm from the north, but I'm trying not to be rude. So just to begin, the goals of the presentation, I want to, and again, I'm probably not going to read the slides, or not very many of them, because we all can read. So I'll have that on here, and then I'll hopefully, build off of that. But I want to emphasize, I'm a lawyer. I'm not a physician. I'm not a clinician. I know how to put on Band-Aids. That's about it. And I know how to use the internet to diagnose all my medical conditions. But that's about the extent of my medical knowledge. So you all really have to, I hope that you take the information that I have and then go ahead and apply it. One of the things I really want to do is to try to give justice, to the AMA mission, which is to advance the art and science of medicine and the betterment of public health. And the concept of public health and public health interventions will go throughout the talk. But first, let's take a look at some of the data. And how did we get to a place where CDC now estimates opioid-related mortality has increased from about 36,000 last year to more than 50,000, according to provisional counts for 2016. And a lot of what I talk about today is going to be really sad and whatnot, and I sort of apologize for that, but I'm going to try to highlight and state the facts, because we have to have facts when dealing with these issues. One of the things about this slide that I want to highlight, in this slide, basically opioid sales to opioid deaths, to opioid treatment admissions. And you can see from that top line, that green line, it tracked pretty well. The more opioids that were in the supply chain, the more people that died. And death from opioid analgesics, your Vicodins, your Norcos, that was what initially drove the epidemic. And you can see that it started, more than 15 years ago is how we got here. We're not going to get out of here. We're not going to get out of this epidemic, in a short period of time. But there are a number of things we can do. And just to point out the changing nature of this epidemic, while prescription opioid-related mortality has continued to increase a little bit, and you see that in the natural and semi-synthetic opioids, your oxycodones and oxycontins. That blue line with the diamonds, mortality from synthetic opioids, your fentanyl, your carfentanil, the stuff that's coming in from China, and heroin is vastly increasing. And this only goes to 2015, but keep in mind that synthetic opioids now have, your fentanyl and illicit fentanyl analogs have now passed the 20,000 mark. Prescription opioids are still at around 13,000, 14,000, and heroin-related mortality has gone over 15,000 deaths. So the factors that initially brought us here, that fueled the epidemic, or that drove the epidemic, are no longer the factors that now are fueling the epidemic. We still have a long way to go on the prescription side, but the public health interventions are going to be different for the illicit opioid side. And the common denominator here, though, is treatment. And two of the things that I think we all have to, at least from the AMA's perspective, that we believe and we strongly believe in our leadership continues to emphasize to policymakers wherever we can, is that unless and until we increase access to treatment, and that includes treatment for chronic pain, and that includes treatment for substance use disorders, unless and until we increase access to comprehensive care for pain and treatment and substance use disorders, we're not going to get out of this epidemic. These numbers for 2017 are going to become worse. So what is it going to take for us to get better? Treatment. And that's where I think we all come in. This is just a different visual representation of how heroin and fentanyl are the driving factors of this epidemic. And if it looks like a scary mountain, it kind of is. But one thing that we want to highlight, and a lot of the policy interventions around the country, and I'll talk about some of the policy interventions, at hospitals and in individual and small group practices and large group practices that you can take away from this, is about morphine milligram equivalents. And one question to think about off the top is, do you know in your practice what is the MED or the MME, what is actually happening in your practice with respect to prescribing for opioids and with respect to prescribing for opioids and benzodiazepines together? And this is just to demonstrate the massive regional variation in MMEs prescribed. We don't really know, people don't really know why this is happening. A lot of hypotheses. Again, I try to stick to some more facts. I don't like to speculate. But what we do know about the facts is that there's tremendous regional variation. If you can see Alabama, there's tremendous regional variation even in Alabama. But even that's not alone. Look at one single point in time. But we have to look at change over time. And the lighter colors here, are decreases. The darkest color is a slight increase. And you can see even in Alabama, there has been only a couple of counties where there's been an increase in MME prescribed per capita over time. So yes, while Alabama still ranks number one as the most per capita prescribed in the nation, even in Alabama, things have moved downward. They've progressed. we could say. And I'll talk about a couple of other factors that in Alabama and across the country, things have progressed in terms of fewer MMEs prescribed and fewer overall prescriptions. But even in Alabama, there's tremendous variation. Why is that? And that's one of the questions that I think is important to keep answering as people who are ensconced every day in quality initiatives and public health interventions. Why does that variation occur? And people in every state are trying to figure out, why does this variation occur? One of the physicians I worked for early in my career at the AMA said, we're not average people, but we don't like to be on the high side or the low side, of doing things. And there are, of course, variations to that. There's some, physicians who have a very complex pain practice or oncology practice might, in all likelihood, prescribe more opioids than other people. Is that why there's the variation in Alabama? I don't know. But that's where we have to take the data and take a look at that. Why is that happening? And then start to understand and then potentially deliver some solutions to that. Nationally, PDMP use, prescription drug monitoring programs, those great databases that I'm sure are used in your facilities every day, and they're being used to identify the data of the prescribers in your practice every day. And if that sounds sort of weird, more and more physicians are using these, more and more healthcare professionals are using these databases. Not all databases are the same. In some states, they allow delegate access. I believe in Alabama now, delegates can now access the PDMP. In some states, they're integrated into the workflow. In other states, they're not. In some states, you can go ahead and share information about the PDMP with the patient. So you can show the patient, look, I see that you're getting prescriptions from 3 different prescribers. Let's talk about that. Is that patient a so-called doctor shopper? Or is that patient somebody who has uncoordinated care? There's a vast difference. And so you can look at the data, use the data to understand, why is this happening? In your facilities, you don't want your physicians and other healthcare professionals prescribing opioids on top of opioids on top of opioids on top of benzos on top of muscle relaxants and so forth. But if you don't have the data, you don't necessarily know. The same thing with prescribing. Now, the national average, the decrease of prescribing, 2 points to this total opioid prescriptions, and this is opioids dispensed. You can see it's going down nationally, about 15% nationally. Alabama is about 17% nationally, so Alabama is beating the national average. But it's still a lot. 215 million prescriptions. I joke that I'm a lawyer, so I don't know how to do math. But if you scribble on the back of your envelope 215 million prescriptions and about 30 million pills or 30 pills per prescription, which is on the low end, think about how many pills are in circulation. Tremendous amount. Again, Alabama opioid prescribing per capita, a little bit closer look. I'm sure everybody's looking at their county there. Why is that? And if you're in the lower color, not all of Alabama is at 1.2. That 1.2 figure, the most recent figure that I have for 2016 for per capita prescribing in Alabama, that's not everywhere in the state. So why are some regions lower than others, and why are other regions higher than others? That's something that people in this room, getting together with your expertise, knowing your local community and your practitioners, I would encourage you to get together and try to figure out, why is that happening? But you have to start with the data. And the same thing with opioid prescribing growth. While most of the state has a decrease in opioid prescribing, and that's the blue colors, there are a few states that are in that orange range, that are in that high colors. Why is that? Is that because there's a new oncology practice in that area? I don't know. That's something that Alabama has to take a look at in terms of developing those quality initiatives to normalize procedures. Before I get going, one of the points about all this tremendous amount of drugs in circulation, of opioids and other unused and unwanted medications in circulation, one of the things to think about, what are the effects of these unused and unwanted medications? One of the easiest, and I say easy because I am standing up here and I don't have to actually do the work, one of the easiest policy interventions and protocols that you can implement in your facilities today, maybe not today, but maybe tomorrow, maybe next week, maybe next month, is how are you educating your patients about safe storage and disposal? When a patient is discharged, who is telling that patient what to do with unused medication? Let's say the patient, we hear the story all the time, I didn't want 30 pills in my pill bottle. I didn't want that, but the doctor gave it to me. Well, at discharge, how can you tell that patient, all right, you didn't want the 30, here's where you go to dispose of it, to safely dispose of it. If you're going to dispose of it at home, here's what you have to do at home. Is that going on in your practice? That practice alone would help, avoid the kind of situations where we have just this massive amount of diversion. More than 70% of people, and that's a high statistic, more than 70% of people get opioids from friends or family. So while, yes, that did start with an original prescription, the people misusing opioids are getting it from friends and family. And that's a direct area where I think you could have immediate impact, low cost, high intervention. Since I'm a policy guy, I want to talk policy for a minute, just to show how it affects you a little bit. I know we have our friends at Blue Cross, here in the room, and so I want to highlight, a couple things, and props to Blue Cross for removing prior authorization for medication-assisted treatment. It's one of those policy interventions that the AMA has been pushing payers across the country to do. There have been a few who have done it with sticks, and others have done it with carrots. So, kudos to Blue Cross for doing it here, the right thing to do. One of the other things that's happening across the country are a tremendous amount of new guidelines on physicians and other healthcare professionals. And this is primarily with respect to opioid prescribing. Which one of these should your physicians follow, your nurses follow, your PAs? Which one? I mean, we have CDC telling us that, saying that an opioid prescription should really not be for anything more than 7 days for acute pain, no more than 90 morphine equivalent. Well, if that's for acute pain, how does the pharmacist at the pharmacy counter know that's for acute pain? Maybe they do, maybe they don't, maybe they have a good relationship to the patient. But what we're hearing about more and more are patients with chronic pain, patients with cancer. A colleague of mine at the AMA, mom was on hospice. She was in her final days, but went to the pharmacy counter to pick up her prescription, and the pharmacy refused to fill it. And it was a prescription for liquid morphine. And the pharmacy refused to fill it because he had just filled one a few days earlier. Well, mom needed more morphine as she got further down the road, toward passing. But the pharmacy refused to fill it. And why they refused to fill it? Because of a protocol. And I don't know if it was the payer or if it was the PBM. But at the point of the pharmacy, the pharmacist has every right to do that. But mom, suffered in her last days. And those kinds of stories, we hear more and more of those kinds of stories. And that's the kind of unintended consequence of certain policies. CDC didn't intend that to be the consequence, of course not. But when you have different policies like this, how are they going to be implemented? Our friends at Express Scripts, Optum, and Caremark, they have 90% of the PBM market in this country. So they have a new policy that's implementing essentially CDC guidelines. When you go to the pharmacy, Optum, Express Scripts, and Caremark, they believe that they can identify who's an acute care patient and whether this is an opioid-naive patient, just from that prescription. How many people in your practice put the diagnosis code on that prescription? How many people in your practice put the full claims history of that patient on that prescription? Probably none. But these are the unintended effects of policies that are not physician-driven, that are not driven from within the public health and medical infrastructure in our states. And so while everybody wants to end this epidemic, we have to take a look at what are the implications of these non-medical, non-public health interventions. And I would submit to you that those interventions are much better coming from the people in this room than the people who don't know your practitioners and don't know your patients. Nearly all of these policy interventions has happened in the past 2 or 3 years. We have mandates for PDMPs, mandates for continuing medical education, and a variety of other mandates. How many people in this room, and again, I'm a lawyer, so I think I know the answer to these questions before I ask them, which is why I ask questions like that. But how many people in this room are fully equipped to go ahead and electronically prescribe controlled substances for every controlled substance? That, it may not happen next year, it may not happen the year after that, but at some point your legislature is going to think, well, that would be a great idea. And there are about 4 states that now require EPCS. New York requires it for every prescription. Massachusetts and Maine, they're going to be moving to every prescription pretty soon. So these are the types of policy interventions. Think about that, what that would do in your practice. Would it improve quality? Sure it would. It would reduce forgeries. It would improve on a lot of fronts. But think about the cost. Think about all of the things that would be required. Is this something you should try to do anyway? Probably is. But how do we get there? Again, CDC guidelines, those are the specifics to them. And just one more point about the CDC guidelines. Hard thresholds. While hard thresholds may work in some instances, how often do they work in your institutions? How often do they work in your practices? There are always going to be some variability in medical practice. But when you have a hard threshold and that hard threshold is codified into law, that's going to be much more difficult to do. I mentioned the payers, and here are a couple of Blue Cross plans. And again, well-meaning. I mean, we get it. Everybody wants to see progress. But a 50% goal, where does that come from? Think about the quality initiatives that you pursue. Why would you come up with a certain percentage goal? Is it something that looks good to the CMO? Or is it something that's actually evidence-based? I have no idea. And I suspect that the payers have very little idea. These make for good news releases. But as far as actually improving patient care, I think it's questionable. They will reduce supply. And in some cases, it may increase treatment. But and not to be too flip about it, but if you increase the percentage of members with opioid use disorder treated from 100 to 200, that's, again, I don't do math. I don't know if that's 50% or not. But you get my point. If we start low and then we go high, these arbitrary thresholds. The PBMs, I mentioned the PBMs. Take a look and see what is the experience of your patients. I think that's when we start to get at, when do we have to go in and have conversations with the PBMs. And I know these aren't the main PBMs here in Alabama, but it's something to look at. It's something to ask your patients, what has been your experience at the pharmacy counter? And really, as the Medical Association and the AMA and the Medical Association here are good friends, here's the key question. The legislature is doing a lot of things. They're enacting a lot of laws. Over the last 3 years across the country, there have been about 400 new laws passed in the states, several thousand pieces of proposed legislation. When the payers, the PBMs, and the CDC, FSMB, and others institute new guidelines, new hard thresholds, what does that do? How does that conform with the law? And how are your physicians supposed to know what to do? It's confusing. I think it's very confusing. Student surgery in the emergency department. Hopefully I'm going to talk about some of the best practices here, and please remember, I'm a lawyer, not a clinician, so I'm going to present some of the best practices that we've seen, but if you ask me to go into the super attenuated details of this, I may not be able to. What I hope to do is identify just some of the best practices, and if you have some ideas about what are some of the other best practices, that you're interested in a certain type of care setting, let me know, and hopefully, I'll have a good answer. But let's sort of start at the beginning with students, and just again to show you the variability. And these are 2 studies that have come out pretty recently. And what the one from the National Bureau of Economic Research found was where you go to medical school tends to be a very predictive factor of how many opioids you prescribe. Harvard prescribes the least. Not to say Harvard is the end-all and be-all, but it was clear that, and they looked at how physicians fan out across the country. If you go to Harvard, you prescribe the least. And then it changes, as you go down the list. And it's by ranking. I know there's controversy over how schools are ranked, but that is predictive. The question I have for everybody in here is, If you're involved with medical school, what are students being taught today? And the answer is probably, I don't know. I mentioned earlier, part of my former background is in PR before I became a lawyer, and when an organization has good things to talk about, they talk about it, right? They want other people to talk about it. And I think the reason you don't hear from a lot of medical schools is they don't have a lot to talk about in terms of what's happening. And the opioid prescribing education, this survey of program directors, a little bit troubling. I mean, I would say it's a little bit troubling. Because residents are clearly prescribing, but few are being actually educated in a didactic, formal way. Not to say that residents aren't very experienced physicians already. They've spent a couple thousand hours already learning how to do what they do. But if we don't train the next generation of physicians, where are we going to be in a formal didactic way? Massachusetts is one state, and again, I'm not from Massachusetts. I don't even like the Patriots. So I have no special love toward Massachusetts. But it's the one state really that we know of where all the schools in the state, through an agreement with the governor a couple years ago, instituted core curricula for every medical school. So every medical student in the state is going to be receiving education in these domains. That is the type of statewide policy intervention that I would suggest is the best practice. Let me talk a little bit about surgery. And as you're reading that, the point I want to get here is surgery, and there's some more research is coming out all the time. And what the data is essentially showing is that opioid use in certain surgical procedures tend to be predictive of long-term opioid use. And where that started was, well, what are we actually doing in surgery? And there have been several studies in surgery, whether it's looking at a set number of procedures, and really at institutions, I'll go through them in a second. But the idea is that what are we doing in surgery at our institutions from a normalized protocol standpoint that work for the physicians, that work for the patients, that improve patient outcomes, and so our patients don't become long-term persistent users. That's what these studies are doing, and all of these studies generated from within the medical community. And again, what's happening in your institution. One of the other things about a new report from a group called Quintiles IMS. One of the other things that this report found were vast discrepancies between persistent long-term opioid use among men and women. And so just as there are many other gender differences between how men and women are treated and the outcomes of men and women, it appears that persistent opioid use associated with surgical procedures also is one. So as you're looking at the data in your institution, again, breaking it down by gender is very important. Surgical protocols at Dartmouth-Hitchcock, 5 common surgeries, wide variations in prescribing. The key here is that they developed the guidelines. First they looked at the data, then they developed the guidelines, and guess what happened? Improved outcomes, fewer opioids prescribed. They didn't need the legislature telling them to do this. Vermont since has passed, Connecticut and Vermont since have passed laws about opioid prescribing, but that's not what generated the interest from the physicians. They wanted to improve outcomes. Physicians I've worked for them for 20 years, they're strange animals. I say that with all due respect and love. You want to improve outcomes. You want to do what's right for your patients and what's right for your practice. This is one good example. Another good example is what you can do in your emergency department. Just like the trend lines for everything else, the trend lines are going up for overdose and inpatient stays associated with overdose. Tremendous amount of cost associated with that. And so in the emergency department, what can we do? Well, I think, there are 2 things that we can do, or the 2 things, it's easy for me to say, 2 things that I would encourage you to take a close look at. One is encourage, what are your protocols for co-prescribing naloxone to patients who enter the ED and who leave the ED? Not necessarily for an overdose event, but when you're screening for risk, at what point does that trigger a decision, maybe this patient should receive a naloxone prescription? And if that's the case, what protocols do you have in place? What education do you have in place in your facility? How do I talk to the patient that they may be at risk of overdose? Without calling the patient, without triggering in the patient, what, you think I'm an addict? You think I'm a junkie? You think I have a problem? Well, we don't have those conversations surrounding EpiPens. We don't have those conversations, surrounding other types of prophylactic medication that you might offer just in case. Those are examples of good just in case options. My 5-year-old maybe has a walnut allergy. We're not really sure. He had one reaction, sort of. But we still carry that EpiPen Junior around. So if a patient is at elevated risk for overdose, maybe it's a patient with sleep apnea. Maybe they have some other comorbidities that would increase their risk of overdose. Should that patient get a prescription for naloxone? It's a question I would encourage protocols to be developed to think about. The other thing in terms of, and I'll talk about this later also, in your emergency department, the data is pretty darn clear. Can you initiate buprenorphine treatment from your emergency department? Long-term survival rates and showing decreased relapse rates, very positive. But if you initiate buprenorphine from your emergency department, or from your practice following a patient, do you have a physician who can do that, who can provide that training in your practice? Do you know where to refer a patient for treatment if you don't have one in your practice? These are the kinds of questions that I hope you leave here. And for treatment of substance use disorder, if you have a patient at risk, where are you going to send that patient? And is that a patient who, or is that referral accepting new patients? And that's where, I hope our friends from Blue Cross who are in the room start to work with us. Start to work with us at a national level to help us understand where are the physicians in the state of Alabama who are currently accepting patients for the treatment of substance use disorders. Where are they? We've gone through round and round of network adequacy, legislation and policy. But how can we now work with you to identify how to get our patients into treatment who need treatment? We all know that treatment that is delayed often results in increased harm. And if a patient spends, one of the common things that I know a lot of institutions do is they give the patient a referral sheet. Here are the 3 or 4 referrals for, where you can get treatment for a substance use disorder. After calling those 3 or 4, and we've heard this story, sadly, far too many times, and they're not accepting new patients, is that patient really going to call a Department of Insurance and say, look, I bought health insurance and now I can't get a referral? No. It's probably going to be a much sadder situation. So with respect to the emergency department, one other aspect, and to talk about, we talked about this earlier in our physician breakfast, and this is something that I think you'll start to hear a lot more about nationwide. As health information exchanges become more robust in states, emergency departments that talk to each other. And I would say think about this at a different level in your community. How in your community can practices talk more effectively with each other? As a statewide effort, that's a complicated discussion. I'm not a tech guy. But that's the kind of discussion. If everybody's using the PDMP, and the AMA doesn't believe in mandates, but we believe in, if physicians have effective tools, or if there is an effective PDMP use through delegates and workflow that you have worked on in your practice, and it's working in your practice, how are you sharing that across the other facilities in your community? So everybody can be on the same page with respect to that information. Overcoming barriers to care. I mentioned it before, and I'll mention it a few more times. Unless and until people are treated for pain and treated for substance use disorders, we're going to continue to see opioid-related mortality increase, and the pressure on physicians increase at the same time. One of the things about reducing stigma and increasing access to care, only about 20% of patients who have a substance use disorder in this country actually get care. It's for a complicated set of reasons. Stigma, there's certainly capacity issues. That's something I think, working on in the state, understanding where the treatment providers are, and then access. Thank you again to Blue Cross for removing prior authorization for MAT. Now it's important that that physicians who are trained for MAT consider taking those patients. Difficult patients, no doubt. But there are resources to help. One of the resources that I think, if people aren't aware of the Prescribers Clinical Support System, it's a national organization. It's run by the American Academy of Addiction Psychiatry. The AMA is a partner, addiction medicine, pediatrics, ACOG, all the largest physician organizations in the country are partners. One of the things that they do, not only provide no-cost education, but one of the things that they have available are mentors. So if you're wondering, how can I increase treatment in my facility? How can I do that? They have mentors who are doing it. Physician to physician, talking to each other. And I'm sure we could connect quality officer to quality officer. So we don't have to reinvent the wheel. No need to do that. We can put you in touch with the right people at the right time. And again, one thing I hope you also leave here, for those that have emergency departments or urgent care or acute care, what are your protocols to initiate treatment? Are there any? The study I mentioned here, the study here is that initiating buprenorphine from the emergency department, it has a direct and meaningful impact on increasing access to treatment. Another best practice model, Vermont hub and spoke. How many people are familiar with Vermont's hub and spoke model? I love talking about it because I ride bicycles, and anytime I can talk about bicycle terms, I feel like I know what I'm talking about. But the hub and spoke model is basically you have, right there in the center is the actual care. What does that care coordination look like in the center? And then throughout the community, and Vermont has done this, and again, it didn't happen overnight, but this is something that perhaps could happen in both large and small cities, both well-served and underserved areas. If there are areas in your community that have, social services, that could easily be, that could be a spoke. If there are services with mental health services that may not be directly in your area, because I know mental health services are really hard to come by in a lot of states, including Alabama, but that could be a spoke. So that's where it takes the hard work to identify who is providing this treatment. And this, again, is where our friends in the payer community can really be helpful, because they know who's under contract. They know where the treatment providers are. And working together, we can identify, it doesn't have to be a statewide hub and spoke model like it is in Vermont, but there can be much smaller hub and spoke models, in your local community. Project Echo. How many people are familiar with Project Echo? All right. This is such a cool program. Project Echo was started at the University of New Mexico. And again, and I should say, the AMA doesn't have any financial interest in any of this. I'm just identifying what's been working. And I'm really just scratching the surface. But I wanted to highlight a few of the main things that are working. Project Echo started, like it says, in 2008. And basically, they took advantage of the fact that the University of New Mexico, which is a large academic medical center, they had some experts, right? That's what happened. UAB, they have some experts here. Those experts, it's kind of hard for them to get around across the state. But it would work like this. Let's say there's a family practice in some other part of the state. And at UAB, there are addiction medicine specialists. There are chronic pain specialists. There are mental health service specialists. What they do is they literally do like sort of a grand rounds. They do case review. So that people in remote communities via the web, then they'll do this at periodic intervals. They'll bring everyone together in a grand rounds to discuss cases. So that way the people who have been doing this the most at UAB, and I don't know if there's jealousy toward UAB. I always feel weird about saying one institution is better than anybody else practicing in other areas. But so if UAB has a certain level of expertise, then let's take advantage of that level of expertise and start connecting that throughout the state. Let's start teaching other providers throughout the state on how to go ahead and provide care for complex patients. It's not providing direct care, it's doing essentially case review. It's a train the trainer type model. But it's another sort of, if you think of it as like an electronic kind of hub and spoke model. It's one way to take advantage of limited resources. And again, New Mexico, top among the states among waivered physicians. They still have a large opioid epidemic like every other state, but this is one of the ways that they're helping. And Project Echo has a number of different ways it's providing care. Additional strategies, I mentioned remove prior authorization for MAT. And here's one, on the policy front, there are laws in the state of Alabama, and there are laws, that cover the entire United States that require a certain level of coverage for substance use disorders and mental health services. Payers are required to abide by those laws. The question is, I mentioned 20% of patients actually get care. And I would suspect that even the payers don't really know how much care they're providing to their patients. They don't know when a patient calls up and the provider in that area isn't accepting new patients. They don't know. This is an area where we can work together. It's also an area where, the Department of Insurance and the Attorney General has an obligation to go ahead and enforce the laws of the land, the laws of the state of Alabama. We'd rather have carrots, right? It's better to catch bees with honey. People still say that? I'm trying to teach my 7-year-old. It's better to catch bees with honey. He's just scared of bees. And also one of the other additional strategies. I know this is controversial in some states, but the state of Virginia, as a Medicaid 1115 waiver, vastly increased reimbursement to hospitals and to practitioners, mostly physicians, but certainly for social services and mental health services as well, for the treatment of substance use disorders with MAT. And it increased, they waived Medicaid's 16-bed limit, and they increased payment. And guess what happened in the state of Virginia? Treatment is vastly increasing. More providers are providing treatment, more facilities are providing treatment, and Virginia has a tremendous amount of underserved and rural areas. Those areas are now seeing treatment in those areas. So even though an 1115 waiver and Medicaid expansion might be controversial in this state, it's being demonstrated that it increases access to treatment, and in years to come, I think we'll see that it reduces death. Some of the other areas of treating pain, let me talk a little about health systems. Let me see how I'm doing here. I think I'm doing okay. Health systems. St. Joseph's Health System in New Jersey started out really just like, one hospital kind of system. State or system-wide protocols, and that's the point. And you can see some of the positive results here. Not a one-size-fits-all solution. And now even some of the larger health systems are looking at the smaller system to see how are you doing it. In some cases, the care is more expensive at St. Joseph's, but the societal benefits and the benefits to the patient greatly outweigh that. And that's what they're doing, the St. Joseph's healthcare system in New Jersey, smaller system. Big practice, Kaiser Permanente, the Permanente Medical Group in Northern and Southern California. Again, what they did was they looked within the system, within the entire system, and I know it's expensive doing all that kind of data analytics, but they looked through all the databases to see what are the variations in care in our system, and what do we need to do to improve outcomes and reduce death. Remember, those are the two most important data points. It's not, ultimately, do we care how many people use a PDMP? No, we want to reduce death and improve outcomes. If we can do that, and that's where Kaiser is going. But look, it started with recommendations, identifying the workflow, implementing education, and continuing to measure, and continuing to communicate. Everybody has bought in. This can work on a large level. This can work on a small level. Kaiser Permanente in Colorado, totally different system, much smaller Kaiser group in Colorado. And granted, not everybody has access to 15 different specialists. I get that. But that's where in the community, I'm not saying it's easy, but I'm saying that's where it's essential to do the work, identify who is available to do that work. And then the University of Chicago. They, again, at the institutional level, they decided we have to look at what the variations are. What does the data tell us? They went to after getting the data, they went to the department heads and discussed, look, there's this huge variation for these 6, 7, 8 different types of surgeries that we're doing. That's not good. We have to understand why that is. So the department heads got everyone else together and started discussing, why is there this variation? And they developed protocols. Again, not one-size-fits-all solution, but protocols. And the initial research is there are reductions in prescribing, there are improved outcomes, and one of the improved outcomes is reduced readmissions, something that we can all learn from. Community Care of West Virginia. Here is something that, also and Community Care has like 6 or 7 different sites throughout the state, but they decided to locate all the pain care, do all the screening through one anesthesiologist, one pain medicine specialist. Rather than have, the different family medicine practitioners throughout the system, have varying things. The anesthesiologist, more training in pain management than most family docs. That's just the way it is. And what they have found are, great improvements in pain care. And I love the quote from him that, this part FBI, part investigator, part CIA, interrogator, part drill sergeant, part cheerleader. He's a physician, right? We know he's telling physicians, the honest truth. Naloxone. One of the recommendations of the AMA Opioid Task Force, again, co-prescribing naloxone to patients at risk of overdose, it stops people from dying. If it wasn't for naloxone, we would probably have 10, 15,000 at least more people who'd be dead every year. So a 40-year-old drug is saving that many lives. What are you doing in your institutions? And I say that, and I try not to be antagonistic saying that. I promise. I know it's hard to institute these kinds of protocols because, again, it's another hard discussion. But through the resources that the AMA has, through other organizations have, through that we work directly with the Medical Association, people have done the work. We have the videos to help educate. Here's how you talk to a patient who is at risk. Take advantage of that. These are some of the resources through a new AMA opioid microsite. One of the things about the microsite is, we realize that, we need one place. One of the things the AMA does is we get everyone together in the same room, and we develop the best resources. The microsite has about 300 or so resources, all from medical associations and other groups like CDC and other public health and harm reduction groups. So we're emphasizing resources that are done by physicians and public health experts. Again, all free, all that kind of stuff. But the resources are there. It's about the protocols and implementing the protocols. Standing orders, I can't recall, does Alabama have, can a patient get a prescription get naloxone? That Mark is shaking his head, yes. Another great legislative intervention. Patients don't need a patient-specific prescription to get naloxone. The quirk here, though, is are the pharmacies carrying it? Do they have it on the shelf? Most pharmacies are trying to do a really good job in getting it on the shelf, so when the patient comes in, they can get it right away. They don't have to come back. There's still issues with costs that have to be addressed. But again, if there's a patient at risk, how are we educating our patients so that a patient at risk can have access to naloxone? Here's something also at UAB and other places. I'm guessing this has happened. I know this has happened in Alabama. Different community organizations can certainly hold naloxone training events. It's happening all over the country. I know it's happened in certain. I meant to have a slide giving some thanks to those people in Alabama who are doing that. But these are trainings that can happen in your community, can start reducing death. Some of the other policy initiatives. I know this is a little bit more controversial. And this is being studied, naloxone upon release from prison. We know that when people leave prison, they may go back to using heroin, misusing prescription opioids, using other medications. So there are a number of areas that are having policies to provide naloxone upon release from prison. It's worth a discussion with your correctional institutions. And Georgia's Think About It campaign. They're holding up a large check here. I don't know how many people in your communities play golf or have fundraisers, but this is the Medical Association of Georgia, their medical foundation. They have a Think About It campaign to help reduce overdose prevention and treatment efforts. And they held a fundraiser, and this was a check for $281,000. All of it went toward overdose prevention efforts in the state of Georgia. Pretty cool stuff. Briefly, what is the AMA doing? I mentioned here are the recommendations of the AMA task force. I think I've touched upon all of those. And I think, again, these are recommendations that have come from physicians to physicians. This is an area where we believe physicians can lead. Those of us who work for physicians, we can help lead them there. So this is an area where, and again, as you've seen in policy and state legislative circles, if we don't lead, the legislature is only more than willing to step in. We've communicated about this quite a bit. One of the things that, and the reason I have this here is that this was from 2015, where the AMA president at the time said, avoid prescribing opioids unless the risks outweigh the benefits, unless the benefits outweigh the risks. And if you do prescribe the lowest amount, the lowest effective dose for the least, for the most effective time. I think you know what I'm trying to say. Don't prescribe a lot unless it's really going to help the patient. And that was pretty remarkable for the AMA to say that. The AMA doesn't like to tell doctors what to do. But we recognize, and we have recognized, much more needs to be done, but that leadership can come from within the profession, within those of us who work for physicians and other healthcare professionals. This is the microsite I mentioned. Hopefully it provides the type of meaningful education and meaningful resources. That's just a little AMA plug. I can't stand up here without plugging the AMA a little bit. I hope you indulge me. And we've organized it by state and specific resources. We continue to add more resources. If there are things from the state of Alabama that you think would be helpful and to help guide people here, all you have to do is send it to me, send it to Mark, and we will get it up here. And we organize it by recommendations. And one final thing, we've worked with Mark. We're working with Mark to update we call it a toolbox. And we're going to get this to every physician in the state. It's on smartandsafealabama.org. To try to provide, the key data about the epidemic and some of the key things that, can be done about it. And, the final thought is, as we go forward, the great thing about what you all do is that you all work from a public health focus. And the people that you work with have a public health and medical focus. And so even though, I know I talked about a lot of things that aren't very fun to talk about, hopefully I've also provided at least a glimpse. I know it was a lot, but at least a glimpse of some of the ways in which people are doing positive things. One thing I forgot to mention, I know neonatal abstinence syndrome is a growing issue here and many other states. There are tremendous resources and multiple good examples around the country. And I mentioned two from Tennessee and Oklahoma at the physician breakfast this morning, where they've instituted the kind of protocols and care protocols that are helping, mom and the babies, ensuring treatment, doing it in the most caring and compassionate way. So those examples exist. And, if you have a question about where things might be around the country, what's working, what isn't working, I much more like to talk about what is working, but I'm happy to talk about what isn't as well. Give me a call, give Mark a call, and thank you for your attention, and I'd be happy to answer any questions. If anybody couldn't hear, the question is, what about prevention? We have talked a lot about treatment, but what about prevention? Primary prevention is absolutely essential, and I'm sure there are other things that I didn't get to today, so I apologize. It's clear it's an omission. It's not because we don't believe it's important, but there are a couple of different ways that prevention plays an important role. And one is, obviously, what is the education that our young people are receiving at the elementary, secondary, and college levels? I remember myself as a college student. If somebody told me to run into a brick wall, I thought it might be interesting. It wasn't, I didn't understand risk, but probably, part of that was I wasn't taught risk. The prevention models that have happened in many areas of the country surrounding, transmission of HIV/AIDS, sexually transmitted diseases, teen pregnancy, youth tobacco use, those have all had public health progress. There's been progress on each of those, and I think primarily due to the education efforts talking about prevention of disease and prevention of transmission of disease. Whether or not those models can be used to help with helping young people understand risk and the dangers of misuse of opioids. Remember, 70% or so of people misuse opioids because they get them from family or friends. So those public health prevention efforts can work. And the question is, and I'm not an expert there, but can those other strategies that have helped in other areas be applied to opioids? I think that's something that, again, I'm not an expert, but I think there are good models out there. The other area of prevention that we do have a direct impact on is medical education and residency education. I mentioned a story earlier where, I talk to residents and students all the time, and one residency director of a family medicine practice was telling me that his residents aren't allowed to prescribe opioids in the rural clinics, his family medicine residents. And he did that for good reasons, because they don't really know how to prescribe opioids, and it seemed that they were like, all the people who were getting opioids for the wrong reasons were coming to the clinic. But when those residents go out into practice, they go into your communities, they're still not going to know how to prescribe opioids. So there's a role in terms of prevention that happens at the foundational, at the foundation for medical students and residents in preventing that long-term persistent opioid use. And prevention also, it goes to the best practices that we develop. Prevention happens, there have been multiple studies. I mentioned just like 2 or 3, and there are so many more surgical studies coming out, showing multimodal pain care. One of the best articles I read about multimodal pain care recently was ibuprofen and ice. It's called multimodal pain care. And for certain surgeries, they were showing it works better than opioids in terms of outcomes. I mean, ibuprofen and ice, like why have a $10 word for ibuprofen and ice? A lawyer probably coined it. I hope that answers your question. Other questions? Well, thank you again very much.